We're here to tell you about our new study that we just published now this week in the Lancet, which looked at citing a new TB diagnostic technology. It's a PCR-based technology, which is currently available in South Africa, but is currently cited in a centralized way in laboratories. And we looked at the feasibility of putting this technology or this machinery in the TB clinic and what would be the potential advantages of doing that. Our two critical findings were, firstly, it was very feasible in a South African context to put this machine in the clinic and for a minimally trained healthcare worker like a nurse to actually carry out this test. That was the first major finding. The second major finding of the study is that it doubled the same-day diagnostic rate. It increased the number of patients starting same-day treatment by 50%. And what this translated into is halving patient dropout. Well, TB is a major problem in our country. It's now officially the commonest cause of death, has a major impact on our GDP. Most of the country where this technology is not available, patients with MDR TB are completely misdiagnosed. We only use smear microscopy. That can't tell you about MDR TB. So people are put onto first-line treatment. On average, it takes 4 to 6 months before MDR is diagnosed. Patients die in the process. Even where this technology is available, the result takes several days to reach the clinic and may never reach the patient. So patients don't necessarily get onto treatment because of this dropout phenomenon where patients never start treatment because either they don't get the results or never come back to initiate treatment. Okay. And one of the things that the Department of Health is looking at and other people are looking at is reducing TB burden in certain hotspots. For example, prisons, certain parts of major metropolitan areas, particularly previously disadvantaged areas where there's a very high burden of TB, and not only that, of drug-resistant TB, which is a major problem. And what our research is suggesting is that this machine can now be placed in such TB hotspots, and that's feasible because we know now that minimally trained people can do this test safely and also as accurately as highly trained technicians in centralized laboratories.
So as Dean of the Faculty of Health Science, I think it's particularly gratifying to be part of such an important project where we're dealing with a very significant disease and disease burden, and where we're showing that where we use bench-to-bedside techniques, which would bring very sophisticated molecular biological techniques that is at the cutting edge of science. We bring that right to the bedside, right to the patient, or as some here say, right to the bundu, where it can make a significant impact on the diagnosis of that disease and the timely treatment and initiation of effective therapy for that disease. Observation that the research that we do here is not just confined to the ivory tower, but it is something that has real application and relevance to the community. And in that regard, we are supporting the Department of Health's policy that this technology should be made readily available.
Firstly, it's a great and a wonderful affirmation of the standard of research that we're doing. Secondly, I think it's an acknowledgement to the whole research team. You know, I just represent the research team, and it's a big multidisciplinary research team, and it's an affirmation of their work. But it's also affirmation of the very enabling environment at UCT, the Faculty of Health Sciences, and also the Department of Medicine.
Research is not only done by the Faculty of Health Sciences, but we should always take care to recognize our partners in this regard, our funders, and also the Groote Hospital in the province, the Western Cape province, and most importantly, the patients who entrusted their care to us.